We shall now go on to our first talk by Dr. Wavikar. Dr. Wavikar, you could share your screen. Dr. Wavikar is an extremely well-known figure in Maharashtra with a great quality practice in Thane, Mumbai. Besides all his prolific achievements, which you're all aware of, what is particularly noteworthy is the software he has created for IOL power calculation, which stuns us about his mathematical genius. And today he will be sharing his take-home message on the perfect biometry for a routine case. On to you, Dr. Vavikar.
Good evening and thank you. Uh, let's start with the beginning. Today, both surgeon and patient want emetropia. And there are too many variables in this. Our job, if we want a perfect biometry, is to reduce these variables. Let us divide the process between the surgeon, the instrument, and the process itself. Role of the surgeon. He has to be a guiding star, but not from a distance. He has to be involved in the process continuously. He has to set standards, train and closely monitor the process and the readings, analyze the results, make changes accordingly, and keep himself updated. Then the instrument, only one line, optical biometry is becoming the gold standard today. But even if you have best of the equipment, data acquisition and analysis requires a different skill set. And then comes the calculation, surgical technique, and the process of analysis. Let us go to data acquisition. Calibrate, calibrate, calibrate. This cannot be underemphasized. It's a very, very important thing to do. There are four more things in data acquisition. Let us look at each of them. So fine-tuning the procedure. Explaining the procedure to the patient helps us in a great deal. Doing all the reading, taking all the reading in an untouched eye, keeping in detail attention to focus to patient position and the fixation. Readings to be taken before the tear film start breaking down. That is, if a patient has a T-but of 5 seconds, you better take the reading within 5 seconds after the last blink. Then we have to take readings in a way that you get three similar readings. Look for dryness. The staff has to be trained not only for fine-tuning the procedure, but for decreasing the person-to-person variation. Then the next point is the validation in data acquisition. There are many guidelines available on Warren Hill's website. I'm just giving one as an example. In actually, this is what we need to do if we want to say that our reading is correct. Checkpoints is something different. In a biometer on a screen, there are lots of numbers and lots of signs. We have to pay attention to all of these. Take a note of all of these. Merely looking at the axial length, the K-metry and the IR power won't do. This is not an exhaustive list, but just some of the examples. And these are the diagrams which help us in assessing these checkpoints. Then comes attention to the detail. This is a patient who had a cylinder of 1.25, and if you see that on the intronasal side, there were 3 points which were missing. After the dryness was treated, these 3 points appeared and the cylinder disappeared. That is how the importance of the attention to the details is. Then we go to the data analysis, compare with other very, very important point. Do biometry of both the eyes together and compare with the patient's refractive error. Keratometry, as compared to before, we are giving more importance. We have to use 3 instruments and each instrument getting us 3 best readings. Then calculation, SI, today the calculation of SI is not important. We can just go by default value of 0.1 because the differences have become subclinical. Net cylinder, we have to see what the patient is going to get at the end of the surgery, and that's why calculating net cylinder preoperatively is very important. Whenever we have got 3 keratometers giving somewhat different readings, Barrett medium K comes to our rescue. But if the 3 readings are too helter-skelter, better rely on static keratometry. IOL formulae, I still consider SRKT with optimization as very good, but I will also see on Barrett Universal 2 and Hill RB. Coming to optimization, initially we used to say it's a definite requirement, but after Barrett suit, the demand has decreased, or the requirement has decreased because the accuracy has increased, but it's strongly recommended still. It's available in all the instruments, and we have to do this by first 1 month post-op data only. Post-op analysis. Every patient has to be checked for residual refraction, sphere as well as cylinder. Exclude those cases where the surgery was not up to the mark. That means CCC overlap was not occur. As an example, take 1 month post-op refraction and introspect properly whether it's a one-off case or a series of cases. So my will be acknowledge and live up to the role of the surgeon, decrease variability, training, protocol, practice, training, protocols and practice. Analyze the process and the results, giving attention to the details and keep yourself updated. Thank you very much.
Thank you so much. I think you gave a comprehensive overview. Today, the reason I chose this topic was that we constantly have discussions about difficult situations, post-refractive surgery, irregular corneas, silicone oil filled eyes. But I think the challenge for us is to hit the bullseye, hit the target in our normal patients, 95-97% of the cases, because all of them are getting torics, multifocus, and obviously emmetropia is something they demand. I would like to start off with Professor Chi. Your comments, I mean, in your clinic, what do you do to achieve this day in and day out on your regular patients?
Yeah, so I think he's covered most of the major points that I would, take care to ensure that they're covered. So for example, if a patient comes in and identifies himself as, wanting to have cataract surgery done by me, then even before I see him, I actually send him for biometry, because I think, doing biometry and acquiring data in an untouched eye is very important. In Singapore, we have a lot of air conditioning, and that dries up the eye, in these elderly patients. And that's usually one of the biggest reasons why these patients can have inaccurate keratometries. So as he pointed out, if you look at the bias of any keratography that's done on these patients, if some Myers are missing, it may be the main reason why you have even irregular astigmatism, or you have higher than normal astigmatism. So I think it's very important that biometry is done before you even see the patient or dilate. And definitely if the patient has had to have an eye pressure check, I would not actually be checking the biometry on that day, or even dilating. You can actually adjust the lens position and so on. So I think that if the patient has got any kind of ocular surface disease, any kind of dry eye, definitely all these need to be treated. If you check the eye later, you have some cornea staining, some punctate erosions, all this actually would require pre-treatment, and you need to explain to the patient that this is very important, because if you want to get that perfect outcome, acquisition of the raw data needs to be really very, very accurate. And I think it's also important that you train your staff to know how to acquire this data properly, because if they are not positioning the head properly, for example, you may get readings that are really off, and when you go into the OR to adjust your astigmatism, you'll be actually adjusting to the wrong axis. So I think it's very important to do that. And he talked about toric, and I like talking about toric because I believe that I want to correct astigmatism completely. And I like to correct it with an intraocular lens, a toric lens, because it actually is able to give me precise outcomes and not something that may be unpredictable. So I don't like to use incisions on the steep axis and so on. I like to adjust that so that it's really accurate. And I think some surgical tips, making sure that the axis is centered, is overlapping, and that you remove all the viscoelastic. All these are very, very important so that you actually have the outcome that you actually calculated. He also mentioned about the biometry, and I believe that in majority of cases, the best formula to use is still to use the Barrett formula. And you must be careful, of course, if the patient is post-refractive surgery, that you're using the appropriate, for example, a true K formula. And today we're moving towards measuring the total corneal astigmatism, especially the more difficult eyes. But I suppose this is for the routine case, and this is what I would do for my patients.
Excellent.
He gave a very comprehensive talk that covered the main points.
Absolutely. Anybody wants to say what about immersion A scan and how to master that? Any of the panelists?
I just want to
Yeah.
add some point because Dr. Wavikar had given a very nice take-home points, and Professor Chi has completed almost everything. And one point, whenever we do biometry, it should be done for both eyes. If you have patient, other eye also has a cataract or even a pseudophakia, you should do both eyes because sometimes it can give you a lot of information about each eye, difference between axial and difference between the keratometric values will make you think for extra things. So that is also important. Don't ignore the other eye in these cases. As far as immersion biometry concerned, we do do a lot of cases where you don't get a good optical readings. I think immersion biometry gives you an equally good reading and more predictable sometimes than done in an optical biometer. Patient is not sitting properly, or uncomfortable patient where patient cannot sit. There are patients they cannot sit. They will lie down, but sitting may be difficult sometimes for more time. So I would understand immersion biometry does have a role even today also, and it is better than doing contact biometry. So that should also be kept into your armamentarium of biometry.
Excellent. Thank you. Over to you, Sri.
Yeah, so one of the points I wanted to make is routinely many of us are using the optical biometers and we take the K readings, axial length, and do the calculation. Sometimes in a mature cataract or evidence PSC, we are not able to get the axial length. So we do the immersion biometry and then take the axial length and put it into the IOL master or lens star and do the calculation. So you should be very careful there because the A constant, optical A constant is different from the ultrasound A constant, and this can give you an error post-op. So if you are going to use ultrasound biometry, then you will have to use the ultrasound A constant when you're doing the calculation even on your IOL master. That is one point. The other point is post-op refraction is very important to assess. It's very important to do a thorough post-op refraction, and you'll have to refract to best corrected visual acuity, because what most of the operators do is they just see 6.6 and then they say patient is fine and then send them. But you'll have to refract to best corrected vision and refract to 0.25 and then put in the readings. We also like to do a post-op biometry and enter the data, because now you have EQ workplace. So if you do the post-op biometry, enter the refraction, it also looks at effective lens position, whether there's any change, and then it further refines your biometry. So these are a few points which I wanted.
All very valid comments. I think most of us, as Professor Chi also mentioned, have shifted over to the Barrett suite almost completely for all our biometry calculations. Anyone in the panel or among the speakers who's sticking on to some other formula?
See, I like to do a Barrett toric calculation for all patients, because sometimes even though they do not have clinical...
What I was trying to say was, we use the Barrett Universal for normalized, Barrett toric calculator for the toric calculator, Barrett True K for post-refractive. Like that, we have shifted almost completely to the Barrett suite. So
yeah, but then the thing is, it is better to do a toric calculation, because sometimes even though the patient does not have a cylinder, it will show that a cylindrical toric lens is required, because of the posterior corneal astigmatism. So it's always better to do a toric calculation and see whether the patient needs a toric and then consult the patient, because sometimes we see that the patient doesn't have a cylinder, or the keratometry there is no cylinder, and then we say, okay, you can go in for a regular monofocal, and then when we do the calculation, it shows up like a toric. So always do a toric calculation, do the biometry before counseling the patient.
Absolutely, I can't agree more with you. Suresh, in this connection, would you like to just mention something about the TK, total keratometry, the concept, and what...
Essentially, with the advent of the IOL Master 700, which gives us the swept source OCT, there is basically a projection of rays from, and the area where the anterior corneal keratometry is being measured. Within the same area, the posterior keratometry is also being measured. So here we have a device where we are able to directly measure the posterior keratometry, at the same time have formulae like the Barrett TK or even now the Haigis TK, which are adapted to the to the values provided by the IOL Master 700, helping us further refine outcomes. One good thing is, since you're measuring it directly in every patient, even without going into the Barrett toric calculator, sometimes it gives you a direct glance at whether this patient will require a toric or not, because you're already computing in the values of the anterior and posterior cornea. And that has really resulted in a sea change in the way we are counseling our patients. Like Dr. Sriganesh sir correctly mentioned, we are clearly doing this before we counsel our patients. And definitely a lot more people are being counseled for toric nowadays than before.
I would like to just add one warning about the TK. If you're using TK, then you have to use the Barrett TK formula, because you can't use total catometry and use some other formula that will give you error.
Yeah.
Plus, when you're doing incisions, when you're programming incisions, either LRIs or your femto incisions, please do not take the TK values, because they will be different from the anterior case, and most of the nomograms which we use are the anterior case. So always take the anterior K when you are programming your femto.
I think it's been a nice presentation, a good discussion. Basically, we want to leave behind a take-home message. I believe that when it comes to biometry, there are two aspects to it. One is acquisition of data and usage of data to get the optimal results. As far as acquisition of data is concerned, all of us would agree that optical biometry would be the way to go, and there are excellent instruments available today. But not all of us can afford it. So even in case you have a good immersion A scan, and you are yourself or a trained biometrist is doing it constantly, you can get excellent results out of it, except some outliers. And when it comes to using this data for arriving at the intraocular lens power, I think most of us would agree that the Barrett suite is a great way to go. And the good thing about it is it's available both in the ASCRS, APSCRS websites to all of us free of cost, even if you are not a member. So even in centers of ours where we do not have an optical biometry, we have made it a point to use this, and I think our results of IOL power calculation has significantly tightened up. And I think each and every one of us should ensure that at least 95% of our normal patients end up with less than 0.5 diopters of residual spherical equivalent error. And I think toric intraocular lenses will also play a big role in achieving that. If any last comments, otherwise we'll go on to the next speaker.
Can I say?
Yes, Wavikar. Yeah, please.
Yeah, 2 points. We go by Barrett suite for the first eye, but when it comes to second eye, it is important to see the IOL power on Barrett suite, Barrett to heal RBF as well as SRKT optimize. Because suppose you are left with a plus 0.5, okay, and if you look at the power, IOL power of all the 3 formulae as recommended, you definitely get an idea what to implant in the second eye. We are doing a study on TK versus Barrett nomogram for corneal astigmatism, and the initial results were saying that for low astigmatism, Barrett TK is better than the Barrett universal 2. That means Barrett toric calculator.
Great, good inputs. I think we can keep on discussing this, but we have to move on. Over to you, Chitra.
Yeah.
Thank you.
That was an excellent talk by Dr. Wavikar.